Hi, everyone. This is Terry Kearns. We'll go ahead and get started. It looks like we have committee members on the line. This is the May 7th Statewide Substance Use Response Working Group Subcommittee of the SURG. And at this point, we'll see if we have quorum for our committee.
I was letting people in. I will call roll. Shayla Holmes.
Present.
Dr. Terry Kearns.
Present.
Nancy Lindler.
Present.
Christine Payson. I don't hear a response from Christine, and I don't see her on the call. But with 3 of our 4 members, we do have a quorum.
Okay, we'll go ahead and continue on with the quorum. If Christine does happen to come in, please let us know.
Okay.
At this point, we would like to open up the meeting to public comment. If anyone has public comment to make, it will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. And this is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If you are dialing in from a telephone, please dial 669-444-9171. And when prompted, enter the meeting ID 868-3331-1069, and then press *9 so that the host can prompt you to unmute. And I'd just like to add, I see that Christine Payson did join us, so we have our full committee in attendance. If there's any public comment. I don't see any hands raised.
Chair Kearns, it looks like Lauren Beal just came off mute. Oh, now she's back on, or they're back on. So maybe that wasn't an attempt at public comment. It doesn't look as though we'll have any public comment for this period.
Okay, at this point, we'll move on to the next agenda item, which is agenda item number 3, to review and approve the minutes from the March 25th, 2024 Response Subcommittee meeting. Committee members, do you have any proposed changes, or would anyone like to make a motion to approve the minutes?
This is Shayla. I'll make a motion to approve the minutes from the March 25th meeting.
Thank you, Shayla. Any second?
Christine Payson, I'll second.
Thank you, Christine. So we have Shayla Holmes making the motion and Christine Payson seconding. At this point, we'll take a vote. All committee members in favor of approving the March 25th, 2024 Response Subcommittee members, please say aye. Aye.
Aye.
Aye.
Any opposed? Any abstentions? Hearing none, the meeting minutes from March 25th, 2024 Response Subcommittee are approved. At this point, before we go on to item number 4, I just did want to highlight, in case anyone was not aware, today is National Fentanyl Awareness Day. So if you see activities in your community, please support those for National Fentanyl Awareness Day. And now I will turn it over to our agenda item number 4 is a presentation on organ donation relative to the narcotic epidemic. Angela, we'll turn it over to you.
Good morning, everybody. Good morning, ladies and gentlemen, members of the committee. My name is Angela Bohr. I am a nurse by trade, but I'm also a certified procurement transplant coordinator and the supervisor of organ services here at Nevada Donor Network. I just want to take a minute to thank you all for this opportunity to speak relative to this topic that affects many nationwide. And how it is relative to organ donation. This topic is very near and dear to me, as I previously noted, and this mission that I serve every day. So for a little bit of context, the entirety of my nursing career has been in either the transplant or the donation community. Early on, I was exposed to the beauty of a second chance that donation can give. But after moving home here to Las Vegas, where I was born and raised, I was given the opportunity to work for Nevada Donor Network, bedside with organ donors, and to witness both the pain and the beauty of donation. Next slide, please. I do not have any disclosures for this presentation. But today I do want to give you all a little bit of a glimpse of the impact that this fentanyl narcotic opioid epidemic has had on the donation community. It has come to the forefront of being one of the #1 leading causes of death to date. It has taken its toll on many families, throwing them into a world where guilt and loss have become their new normal. Nevada Donor Network actually is one of 55 OPOs across the country, organ procurement organization. I apologize for the acronym, but we continue to strive to give these families a glimpse of hope and light during the darkest of times. And our mission is to save and heal lives, which is rooted to the core of everything we do on a daily basis. So some issues I just kind of want to talk about today are fentanyl narcotic epidemics leading to the unintentional overdose that we see on a day-to-day basis, the effects of fentanyl and the narcotics on an organ system, and then the life-saving and life-altering effects that happen with respect to overdose, drug intoxication, and donation. So next slide. So when taking into consideration some of the special populations, it is a bit difficult to articulate the impact this epidemic has had on just one population. But when looking at the data, it's pretty evident that all populations are affected. If you go on to my next slide, please. So taken over the last decade, this actually represents a decade's worth of organ donors that were actually the mechanism of death that was deemed was a drug intoxication secondary to that overdose. So if we break it down a bit, span it over that last decade, it actually can be found that the white non-Hispanic population year over year contributes to most of the organ donors seen with respect to drug intoxication, followed by Black, non-Hispanic, Asian, and then if you continue to the next slide, it goes into the American Indian, Alaska Native population, Pacific Islanders, multiracial, and then some that are unknown. It's difficult to pinpoint exactly what their nationality is. Sometimes we get a donor that we don't have a family member that can kind of give us that information. So they fall into this little bit of a category. So each of these colors, again, represents a year and the number of organ donors nationally based on that mechanism of death. And then if you want to pop to the next slide. So if we continue to break down that data a little bit further, this breaks it down by gender, and you can see that males consistently struggle with drug use and ultimately represent about 60% of organ donors respectively in the drug intoxication category. Year over year, again, this spans over the past decade. So as you can tell, this trend unfortunately continues to rise year over year, seeing this peak in 2023 last year when we really started to see fentanyl being incorporated with other drugs. And then as of, year to date, currently there are 231 females represented here in the purple, and then 376 males year to date nationwide that again have become organ donors based on that drug intoxication mechanism of death. So if you go to the next slide, we're going to break it down even further for you. So again, year to date, spanning over the last decade, this shows you a breakdown of ages. So you can see down here, the 18 to 49 age span is typically the most affected by this epidemic, based on socioeconomic status. None of that socioeconomic status, population, your heritage, none of that really matters. And so that is evident based on this age group right here. So go ahead and go to the next slide. So as you can tell, over the last 10 years, the organ donors from drug intoxication continues to rise. Again, this graph simply represents those who have succumbed to this crisis and went on to become organ donors nationwide. This does not capture those that were not captured based on their not becoming a donor. The numbers are in the hundreds of thousands nationwide. So many don't make it far enough to, unfortunately, to become organ donors, as you know that they do eventually pass and they're found many hours later, things like that. So that again is not captured here, and it's very heartbreaking, as you can tell. So go ahead and go to the next slide. So this slide here captures the data based on Nevada organ donors. Last year, we had just over 200 organ donors. If you take a look, it shows about 29 of those were actually organ donors based on that mechanism of death resulting from the drug intoxication. And again, this doesn't capture the numbers, the mass numbers that actually passed due to this crisis that we're in. So go ahead and go to the next slide. So just to kind of touch base a little bit on the organ system. So this obviously doesn't capture every single thing, every challenge that we see when we are bedside with an organ donor, but it is apparent that based on whatever drug that they do consume, it has a considerable consequence leading to either a slight or complete dysfunction of the organ system as a whole. Some of those, again, are irreversible, leading to non-utilization of that consented life-saving gift. Organ suitability is evaluated based on the cause, the circumstance, the mechanism of death, while also taking into consideration patient's health history. So someone that has a history of diabetes, things like that, or heart disease, we do see effects on that organ system. However, those sometimes can be an automatic rollout, but we overall, drugs do take a toll, but is something that we do consider, and it is something that is presented to the transplant centers when considering an organ for transplant. But as you all know, long-term drug use can lead to serious issues such as cardiomyopathy, vegetation on the heart, arrhythmias, oxygen deprivation, cirrhosis, and worse, complete organ failure. Go ahead to the next slide. So in working on this presentation, it was, I see my team sees patients after there's nothing left that can be done for this individual. They are either they're diagnosed brain dead, or they are left almost in a vegetative state because they had such a severe anoxic brain injury that led to them that the drugs led to. So some gaps that I could offer, I guess, are treatment for a diverse population. Most of the groups focus on one population, while it's evident that this epidemic is spread throughout all the populations. As I noted before, based on socioeconomic status, your population, none of it really matters because it's evident that it is a problem nationwide. So go ahead to the next slide, please. So some recommendations that I would have, again, this is the world that I work in, is organ donation. So I see firsthand bedside the effects that this has on the loved ones of those that succumb to this. Some examples, I would suggest additional funding perhaps and resources is grief counseling, treatment facilities, family support groups, contributions to local charities supporting survivors to help them find their voice. And here at Nevada Donor Network, we do strive to care for these families depending on that mechanism of death for their loved one, things like that. We do offer different types of support groups. And we offer outreach for a minimum of 2 years for every single family that is affected by losing a loved one and becoming an organ donor. That's not to say that we don't offer these resources to families that say no to donation. We strive to just include everybody in that. So next slide, please. All the data that you have seen today can be found on optn.transplant.hrsa.gov. This is one of our regulatory bodies that oversees all of our data. This is also known as UNOS. They're kind of interchangeable. So if you have any questions about that. And then last slide, this is my contact information. If you guys have any questions, comments, concerns, I'm happy to answer them. I can be reached at that email or by calling 855-NV-DONOR. And that's all I have.
Angela, thank you for your presentation. I know the work you do is very important and can sometimes be very tough to do as
Yeah.
well.
It
I wanted to open it up to any of the committee members if they have any questions. I know I have a couple, but I wanted to allow the committee members to ask theirs first. Seeing none from my fellow committee members, my first question was that I just wondered if, I know that as for organ donation, you have to get a release from the coroner or for the medical examiner. And of those donors that you've approached your coroner or medical examiner for donation, have there been any issues or problems relating to them releasing for organ donation?
That's a great question, Terry. So when we get authorization for a case, or in a lot of cases, if you're a registered brain dead donor, your registry actually takes effect as it's a first person authorization. So in the event somebody becomes a donor, the first thing we do when we get that authorization is we reach out to the coroner's office. We provide that mechanism of death. We provide all of the information that they would need to do a suitable evaluation, typically based on the mechanism of death. So anybody that tests positive for drugs is usually automatically a coroner's case. And so we don't, just depending on the age of the donor, depending on the circumstances, if they were in custody, things like that, we are subject to limitations on what we can get authorization for donation for. It is very rare that the coroner says no, but they do have certain restrictions based upon that patient's cause of death. But again, if they have anything like fentanyl, which most of the hospitals actually didn't start testing for here in Las Vegas until about 6 months ago, because we saw, as you can tell, in 2023, we really hit that peak in about April and May. And so they really started to test for that and things like that, whereas the coroner was doing that on the back end. So again, just to kind of circle back, it's not often we get limitations, but every case is evaluated by the coroner.
Thank you. I appreciate that. And I know you talked about the effects of drug on the organs and the systems.
Yes.
Have you seen, and I know it really probably is contingent on drug use and other past medical history, is there one organ or specific organs that typically you find you can't use, or is it really case dependent?
It truly is case dependent, depending on the length of time that somebody has used a substance. For instance, if we talk about cocaine, as you know, can affect the heart. It can cause vegetation on the heart. It can cause severe arrhythmias, dysfunction. Typically on those, we would have to, every single person that we know that does cocaine, we would do, for instance, a cardiac cath, and we would to rule out the vegetation. In the event that person had some vegetation, that would automatically rule out the heart, cirrhotic livers, things like that. I did most of the things that would rule something out are pretty much up here next to the patient's past medical history. So.
Okay, I think we had another question. Is a prior history of opioid use disorder disqualify a patient as a recipient of a donated organ?
So typically on the transplant recipient side, there is a lengthy evaluation process that goes into play there. They also have to be drug free. They have to be stable. They have to have housing support systems. There's many things that go into that. Having a history of opioid use does not necessarily negate them as long as it's not a current practice.
Great, thank you. And I just want to say, I really appreciate your presentation because I think I uninformedly assumed that the probability of overdose death probably precluded someone from being an organ donor. So you really opened my eyes and I appreciate the information.
Yes, I'm so happy to be here. It is a very intricate process. I'm happy to offer. This was a quick presentation, but there's so much more that goes into it. But ultimately, as long as the patient is found within a reasonable time of that overdose and is brought into the hospital, they have their heart beating and ventilated, we can evaluate them. But in the event that they are, oxygen deprived, their MAP is extremely low, things like that, it would rule them out, as you know, because the organs at that point are not perfused, and it's difficult to determine exactly how long they were not perfused. So that is probably one of the only things that would preclude them. from becoming an organ donor, because at that point they're just so unstable. So,
Yeah, that makes sense.
so
Actually, I did have one other question. And
yeah.
for those of you, I think I mentioned previously, I was a nurse and I worked in the arena of donation. And I know in the past, I saw your numbers in terms of who donated that had overdoses and related to fentanyl. There has always been somewhat of a disparity in terms of donation. And then, for example, in the Black community, often are those that need kidney donation, but typically we're underrepresented in terms of donating organs. Do you still see that? Is there, outreach to those communities in order to try to increase in some of the subpopulations?
Yes, most definitely. We here at Nevada Donor actually have an extensive outreach program. We reach out to populations all represented by some of the graphs that I presented earlier. We do multiple events every single year. We provide that education. We just do a deep dive to ensure that everybody has an opportunity and is informed. Because yes, as you had mentioned, my historical transplant experience was with kidney pancreas transplantation, and members of the African American community, yes, they are at risk for higher kidney disease rate. They're just statistically, their rates are higher. There was actually a study called the Apollo study that touched base on that, just to bring light and shed some light and get some data based on that. We're still waiting on the information on that study. But yes, outreach is a huge thing here, and we do our best to ensure that every population has clear representation and just as much knowledge as possible. And that's something we strive for within our community development team and all throughout the community, truly.
Again, I thank you for the information, and to you and your team for the work that you do. It's very necessary.
Thank
and
you so
difficult.
much. Thank you so much. And thank you for everything you all do and having this subcommittee. It's important things. So I appreciate it.
Thank you. And if anybody has questions, again, she put the contact information up in order to address any further questions. Thank you.
Thank you so much.
Seeing no other questions or anybody coming off of mute, we'll move on to item number 6. Angela, you're welcome to stay with us, or if you need to get on to other things, we totally understand.
Oh, thank you.
Number 6 is, item number 5, overview of prior and new recommendations received and the next steps. As we look at this for the committee members, if you on the agenda look for response 2023 recommendations and a legislation addressed handout, and then pages 62 69 of the annual report of the statewide substance use response working group for the status update on the 2022 recommendations. And also it was noted in our last meeting that the following legislative component had not been addressed in any of our 2023 recommendations. And that was item L in the legislation forming the SURG, which is to evaluate current systems for sharing information between agencies regarding the trafficking and distribution of legal and illegal substances which are associated with substance use disorders, including without limitation heroin, other synthetic and non-synthetic opiates and stimulants. One thing that I did want to highlight is that let me see, recommendation number 11 from our from our last year, our annual report, which was, Crystal, can you by chance bring up the recommendations?
Yes, just in 1 second.
I'll start with number 11 just because it's relevant to the presentation we just saw from the response subcommittee. So recommendation number 11 was leverage existing programs of funding to develop outreach response providers and or personnel that can respond to any suspected overdose or to those who are provided treatment for an overdose in a hospital emergency room, EMS, and offer follow-up support, referrals, and services to the individual and those impacted by the overdose. For example, other persons with a personal and or emotional connection to the victim, surviving family members, and or post-mortem services for family following an overdose. Providers and or personnel to be deployed to anyone being released from institutional and community settings such as hospitals, carceral facilities, and other institutional settings who is being discharged post-overdose or suspected overdose. Ensure this recommendation is included as the build out of Nevada's crisis response system is occurring so that tailored intervention for individuals who have survived a non-fatal overdose is including. And I just wanted to highlight that because as noted, Angela did bring up about support for family and loved ones. They being the Nevada Donor Network, do provide that to families and significant others. But I just wanted to highlight that's probably something we should continue to look at. I think that this is partly being addressed by the crisis response system, but I don't know if that is built into including the family members and significant others or those affected in the crisis response system. And I would defer if any of my committee members know if that is part of the build out of the crisis response system.
I haven't heard too much in regards to the build out at this time. As far as I know, the RFP for 988 is like the top priority on that. And then I do believe the crisis stabilization centers are the next piece. And then Medicaid is also working on the designated crisis response teams, which I believe could potentially be this, but I haven't heard too much in detail about that part of it.
Chair Kearns, Christine Payson for the record. Yeah, I don't know that it's part of the build out, but I know that the sport team that Jessica Johnson over at Southern Nevada Health has been working on is up and running. It's still in its infancy, but that is where they have one of their representatives respond to an overdose scene. Once the police are there and have stabilized the scene, then they'll call them out and have them there to provide a warm handoff and resources. Sometimes, we're again still in its infancy, and everyone's going to respond differently, whether they want to take advantage of that at that time. If they don't, then they wait a day or two and then they reach out again. So there is that type of follow-up happening for overdose survivors, or if the overdose victim doesn't survive, they're still reaching out to family and friends.
Thanks. That's a great update. I had forgotten about the sport team out of Southern Nevada Health District. I do know that in the northern part of the state, we have the most teams, but I think they really focus more on the individual as opposed to the family or significant others or those affected, unless you have something to add, Sheila.
I mean, it depends on the most team really and the state of the individuals. So my most team does have a community health worker. Am I paused? Can you hear me? Oh, I hate it when my internet does that. I love rural Nevada. So like my most team does have a community health worker and a case manager dedicated to it. So if the individual is living with family, we will respond and follow up with family and anybody that is a part of their support team. But if that individual is living alone, then we wouldn't be following up directly with the family. So it just kind of depends on the person. And that's why I mean, I think it's something that we should definitely encourage for most like teams. And I think if I remember, this recommendation came maybe from one of mine that was blended in regards to building out most teams to be able to respond. Because right now, most teams receive referrals via dispatch. And so I think that this could be something that, although it's in this recommendation, something that most teams could pick up, particularly in the rural counties, that they also receive referrals from hospitals on discharge. And right now we're only working with hospitals on discharge for folks that we take in on a hold. So if we're not involved in that hospitalization, we're not getting any information in regards to folks being hospitalized. And I think that that is one way that those teams could be utilized better, to be able to respond to overdoses and provide that true wraparound for the family and those involved.
Yeah, that's a good point. And from my understanding and looking at the crisis response system, it would include most as part of the responders. So it sounds like this is one we would need to continue to follow up with. I also looked at recommendation number 9, which I'll allow Crystal to scroll back to. This was to evaluate current availability and readiness to provide comprehensive behavioral health services to include, but not limited to, screening, assessment, treatment, recovery support, and transitions for reentry in local and state carceral facilities. For example, implement follow-up and linkage to care for individuals leaving the justice system, recommend the allocation of funding to support the development of a Medicaid reentry Section 1115 waiver to increase health care for people leaving carceral facilities and to support readiness of carceral facilities to implement the 1115 waiver, and recommend legislation to require Department of Healthcare financing and policy to apply for and implement the 1115 waiver to increase healthcare for people leaving carceral facilities and ensure there is an evaluation of readiness for planning and implementation. And I just wanted to update the committee members and everyone that this is currently obviously being worked on by DHHS, Division of Healthcare Financing and Policy. And I discussed this with Sarah Dearborn, and she said that there would need to be an amendment made to NRS, and it would primarily be to look at the cost reimbursements and the pricing and those sorts of things. So I think this one is being worked on, and we'll continue to have to follow. I don't think it's something that's going to happen right away, but will be more of a midterm to longer term solution to get this in place. If anyone has any other updates on this one.
I'm not sure. Well, there's currently the state of Nevada Justice. I'd have to go find it. There's a grant open right now. And it's one that my agency applied for to be able to tie peer support specialists upon release through the FAST program. And so I think that that's, and peers in theory are Medicaid billable as long as that individual still has their Medicaid. So if they haven't lost their Medicaid in their stay, which is one of those things where the waiver is not necessary for that at the moment, it just, some people drop off and some people don't, depending on the length of stay. So those peers in theory would be Medicaid billable for folks eligible for Medicaid. I think that part of this too is not everybody that is incarcerated is Medicaid eligible anyway. And so I think that some of these services and ways that, I mean, yes, right. I think Medicaid is a mechanism for a portion of the population, but I think that we also need to find ways for this to be funded long-term for folks that aren't Medicaid eligible. Because I think that that post-release support is really what's going to ensure success for folks. But there is funding right now available via grants that could make these things happen for interested organizations that want to do it. It's just, having that desire and that engagement with it.
Thank you for that, Shayla. And I know we asked Bill Teal to be on. Bill, I don't know if you have any updates. I know you provided a presentation to us on the programs that you're working on for the MOUD. If there's any connection with this, with your program.
The only response I really have for you is the fact that this is being talked about with the different counties and more specifically the sheriff's departments and their leadership teams, just to provide an awareness as to what the 1115 waiver is. And there's state representation who also contribute to that conversation during our multidisciplinary team meetings with the counties that are participating with the jail MOUD approaches that we have in play. But other than that, I apologize. I don't have anything in addition to really report on.
No, I appreciate that. But while we have you on here, I know part of our discussion was the LAPA next steps based on their survey results and discussion at our April 10th SURG meeting. And one of them was to require state and local correctional settings to provide withdrawal management services. So I know you're looking at the MOUD, but MOUD and withdrawal management are two different things. So I don't know if is part of your survey that was included in your survey that you did?
It wasn't in its entirety. What was asked with the different jails throughout the state was what type of, whether or not they already had an MAT program in play. And if they didn't, what were they doing? And so the vast majority of responses was that they had some type of detox monitoring, but not a true withdrawal management type of a program. So there are some, we'll take Esmeralda, for example. I think Esmeralda demonstrates, although they're the smallest county and jail within the state, sometimes they really do a great job of thinking further outside of the box. I know for certain that when they have individuals that come into contact with who are struggling, either are in crisis with substance use disorder, they'll take them to the nearest hospital they can, which at times is either Pahrump or Las Vegas, to get them the care needs that they require. But also at the time of reentry, if they're still suffering from some type of substance use disorder crisis, they'll make that transport to Pahrump or again into Las Vegas to continue that level of care. I know it doesn't really answer your question inside of the jail, inside of the jails, and that's why there's such a big push for the introduction of the medicated assisted treatment program. So I know it's more specific for opioid use disorder, but the engagement allows us to have greater conversation about all substance use disorders and the need for a withdrawal management type of process to include, that bridge to the conversation on behavioral health.
Great, thank you for that update. Any other committee members have any questions for Bill while we have him related to the carceral facilities? Okay, and then the other from the LAPA was the support information sharing with overdose fatality review teams. I think we all agree on this. I know we are waiting for Clark County's report. And then the state OD2A group did a report on this and did describe their recommendations, successes, and barriers. So I think this probably is one we'll have to continue to look at and wait for the information we get from Clark County. And then the only other I had for recommendation number 12, which was a response committee. Sorry, Crystal, I know I'm making you go back and forth. The recommendation from the response committee from our 2023, it was about recommended compliance study to be completed on NRS 259.050, number 3, and 259.053, provide adequate funding for the medical examiner's offices to include death scene investigations, forensic pathologists, forensic epidemiologists, and toxicology testing to determine the specific cause of death. I know I have reached out to the LCB to see if they would be the ones who would conduct this type of compliance study, or who that would be. And then also I've talked to Dr. Knight, and a limitation for them is that grant funding really can't be used. It will only support certain positions, but the majority of these positions are not supported through grant funding. So something that we will need to continue to look at on our previous recommendations. And then the unranked recommendation we had on the wastewater epidemiology. Recommend the Nevada System of Higher Education conduct a feasibility study to understand the true cost of implementing a wastewater-based epidemiology in our state and its ability to support community response plans. Funding for this study may be available through the Fund for Resilient Nevada. I think this is something that we're going to have to continue to look at because I've seen a couple of webinars where there have been a few places that have been using wastewater-based epidemiology to support their community response. So we are trying to reach out to those areas that are using this to see what they're finding and to get better information. And Shayla, I know this was yours. Do you have anything additionally you'd like to add?
No, I just think we should continue to investigate it. Although it was unranked, I do think there's a lot of potential that could come from this type of data.
Yeah, and I know that SEI is trying to reach out to get a presenter to present that have used this wastewater-based epidemiology. So hopefully we'll see that in the near future. And then going back to the PowerPoint, I promise I won't make you go back and forth again, Crystal.
Okay.
I did submit a recommendation. My recommendation was to recommend a BDR for our state to have a definition of recidivism in NRS. And really, this came out of some of the work through the Attorney General's COSUP grant that we're doing with the FAST teams and trying to evaluate the FAST teams. And one thing that we have found is that it's defined differently by different counties. So it's really hard to evaluate when you're kind of evaluating apples to oranges because the definition is different. And we have a possible presenter in Sherilyn Raw Woods and Katie Snyder, who could come and speak more in depth on the need to have a definition of recidivism. I do know that within our state that the Department of Corrections does have a definition, but that doesn't go across all of our facilities. So that was our thoughts. I'd just like to get any feedback from the committee members on this recommendation.
This is Shayla Holmes. I would like us to also consider, and I think, so I promised I was going to put in a recommendation and I haven't done it yet, but I'm going to as soon as we're done here. Because I think this also goes across the data sharing conversation as well, because not only is it a local definition of recidivism, but we see individuals recidivate cross county lines. And right now we don't have any way of being able to define that level of recidivism. So in theory, and don't get me wrong, I love our FAST teams. I fund one, I have one. But I feel something that should be taken into this conversation is not only do they recidivate within my county, but if somebody that had a FAST plan, oh, there I go again. Okay, here we go. So if we had a FAST plan and a service plan, and we were working with somebody out of Lyon County FAST, for example, but they were released and then later arrested in Carson City, I believe that that would be something that the FAST overall program evaluation would want to take into consideration in regards to a recidivism piece. And right now we don't have any way of knowing that unless it's self-disclosed by the client. I know that UNR and Katie Snyder And folks we've used in the past to try to evaluate this program have tried to take that data and like culminate it and figure it out somehow. I don't know what the heck they did, but I think the data sharing piece is a part of that. And I'm going to attempt to put in a recommendation in regards to some data sharing concepts, not just for criminal justice arenas, but some others as well. Virginia's done some really cool stuff. And so I'm gonna put that recommendation in, and that might be something that helps aid this conversation as well.
It's a very good point on there. Any other thoughts from committee members?
Christine Payson for the record. I just want to say that I really like that recommendation. I had no idea that we didn't have a common definition for recidivism. So at least get it statewide. We'd love to see it nationally.
Yeah, and there is like a either a DOJ recommendation. It's in all the information that I provided, or definition of recidivism, but there's nothing national. And in looking nationwide, there's only about, I want to say 5 states that have a statewide definition of recidivism. So that was one of the questions I've asked too. I know that North Carolina has done a lot of work in trying to evaluate law enforcement driven diversion and deflection teams. And North Carolina is not one of the states that does have a definition, a statewide definition for recidivism. But again, you know, we run into that, what definition of recidivism do you use when you're really trying to evaluate these teams? There are proponents both for and against law enforcement led teams. So that's why I think we really need to look at this, especially because we do have those within our state, in trying to get a better comparison of apples to apples instead of apples to oranges. And Bill, not to put you on the spot, but I just wonder, given your background and experience, if you have any thoughts on this recommendation.
I like what Shayla was talking about, you know, the tie-in to, you know, being able to have a proper definition of recidivism, but also as it relates to information sharing. And that was one of our biggest challenges. I remember, you know, well over a decade ago, having the same conversation about the need for access to information to, you know, use that information to help, you know, break someone's cycle. Because in, you know, Clark County, we were very fortunate. We had access to a variety of different resources inside of that jail. And we could use those resources to our advantage if we knew, or if we had access to additional information with their, in regards to their engagement with mental health resources or substance use disorder resources, to make that a part of the effort while they were still incarcerated. The challenge that we had, and it's going to be the same in most law enforcement agencies, is the confidentiality behind that information. Anything that's related towards, you know, if, for example, the ask at the time was for the jail to participate in the community management information system, when it was called the homeless management information system. But where legal drew the line was anything that connected the individual to a jail was dissemination. And so it violated their constitutional rights. I will tell you that during that period of time, and I believe Chicago was heavily involved in, you know, this region of the country, they were successful in changing some language to the legislative session that helped kind of overcome that barrier and work around the information share with consenting individuals. So that was a key word, is like having the consented individual wanting to participate, who had an active interest in wanting to help, you know, help with breaking their cycles. So glad that was mentioned. I would love to see us as a state make progress in both of these two arenas. So grateful that it's an area of interest.
Thank you for your comments. I appreciate that. And I know that in working with FAST, one of the big issues is the release of information, and who that release of information, who is eligible to receive that information. So something that continues to be looked at. One other, and I did not make a recommendation on this, but one of the other ones I thought about was if we wanted to make any recommendation on compassionate overdose response. And I don't know if that would go with any of our prior recommendations, but what we mean by compassionate overdose response is there's been a lot of work done and there's been research done that because we believe someone has overdosed on fentanyl, that doesn't necessarily require a larger dose of an opioid antagonist to reverse it. And there are places that actually rarely even at some of the supervised injection sites where they don't typically use naloxone, for example, and that we've got to get out of the thought of bringing someone to full consciousness as opposed to being able to breathe on their own. And that often people don't even know, some of the folks that I saw at the summit they didn't even know, and some of them were medics, that they were putting the people into withdrawal. So education on this, and then also what constitutes a compassionate overdose response. I do know that I believe that we have asked the Opioid Technical Assistance Center to come talk to us on the Good SAM and the drug-induced homicide and some of the training they're going to be putting on. But I also requested that perhaps they can address some of the compassionate overdose response topics too. So any thoughts from committee members on this one?
I would certainly be interested in learning more about it. I've never heard about it until I heard you speaking of it. I know at the last cross-sector task force that we had, which was some time ago, they were talking about wanting to increase the amount of milligrams in the naloxone that was being distributed through CASAT, which is like the free community-based naloxone for individuals at risk or just community members interested in being armed and able. Knowing the information you've shared, it's like, man, that sounds a little scary and maybe the wrong response. They were also talking about making injectable naloxone available for users and making that available for free community distribution as well. I don't know if that would be the method that is compassionate because it allows for a lower amount, but I also don't know what impact that would have for the lay person wanting to be able to administer naloxone for the safety of like their friends or family. But I would love to learn more. I think it's a great conversation and certainly something that we should explore.
Yeah, and I have suggested these as some presentations too, and maybe we can reach out to some of the people who have done these studies that were at the summit that I saw.
I know every time I do a naloxone training, I promise everyone they don't have to stab someone in the heart like in Pulp Fiction. So as long as we can just keep that steady, I think we'll be good.
Well, and the other piece as I look at this, trying to look all around, is if you are providing this to law enforcement, the inhalational is an easy to use. And I know in the summit in Europe, what they use 2 milligrams or lower. We use 2 to 4. So what we use as low dose, they consider high dose. So law enforcement giving them one thing to use is going to be easier, having to decide, do I use this one or that one, or I have a high dose or a low dose and injectable. So I think from a law enforcement perspective, in my opinion, it's much easier to provide the injectable. Not the injectable, the inhalation, but it's hard to give a half a dose of the inhalation. So just some things to consider. And I know our law enforcement partners do carry it now. I believe all throughout the state do. And many have used it because they are there before fire EMS arrives. So just some considerations. So Christine, I don't know if that's something you would want to take back to the sheriffs and chiefs and get any comment from them on.
Yeah, I will take it back to them, and it's interesting. I just had a conversation with a North Las Vegas firefighter, reference some of the presentations that my partner Lacey, the public health analyst, I give on fentanyl awareness, and we cover Narcan or naloxone, and he brought up the same thing as far as administering that and the dangers that come along with it. I've never heard the term compassionate response before, so I find that very interesting, and maybe we'll be able to incorporate that into some of our presentations.
Yeah, that's interesting. As well, I'm sure you'll want to take the recommendation about the definition of recidivism back to the sheriffs and chiefs.
For sure.
And I don't know if you had the opportunity to talk to them, if there's any suggestions that will be coming from the Sheriffs and Chiefs Association, any recommendations? I think that's probably a no. So we'll go on to the next.
Oh, sorry about that.
That's all right.
I was going on and on. I didn't realize I hadn't come off. But yes, I do hope to be hearing from them soon, because I gave them an update a couple months ago about where we were so far with SURG, and there was interest in the vulnerability study and the top 5 counties that were considered most vulnerable. So I was asked about that particular part of my presentation, and I directed them back to that study and the one slide that showed the top 5 vulnerable counties, but then also the entire study if they care to review that. So I'm hoping after providing that I'm going to be getting some responses or recommendations.
Great, thank you. Any other thoughts from committee members for anything you've got for potential recommendations? Okay, we can probably go on to the next slide, which is item number 6, planning for the 2024 response subcommittee members. Wanted to just ask the committee members if there's anything that you have for an interest or a priority for future members. And then also wanted to remind you to submit any recommendations via the survey that was sent out to you from Crystal. As noted previously, currently some of the topics that Opioid Technical Assistance Center for the mobile response and Good Samaritan law, and the definition of recidivism for June. We do have the request for that, or the Oregon drug decriminalization and recriminalization, but that would be for the full surge in July. The workforce topic that we talked about for basically how the opioid epidemic or the drug epidemic, I would say, has affected the state's economy. So that's in one. Wastewater treatment epidemiology, which we talked about for August, and then the Clark County Opioid Task Force for their report that they are to be publishing in September or October. Our next meeting dates are June 4th, August 6th, September 3rd, November 5th from 11 to 12:30. So anyone have any thoughts off the top of your head that you want to add for presentations? I would just add, Crystal, I know we talked about the compassionate overdose response, so that probably would be one we would want to add, whether that's from the Opioid Technical Assistance Center or others. Shayla, I saw you come off mute.
Within my recommendation that I promise I will submit today, I'll see if I can find anybody that either works for the data company or the software company or somebody from Virginia on what they've done. It took them some legislative changes and then some different, it took them time to get where they're at, but I'll put that in with my recommendation. I don't know how lucky we'll be, but if there's anybody that can report on how they were able to get to their data sharing current state, that could be a good presentation.
I agree. That sounds like a great, could use as a template, perhaps. Hearing no other recommendations, I think we can move on to item number 7, discuss report out for our July surge meeting. I'll turn it over to my co-chair, Shayla Holmes.
The agenda item is pretty self-explanatory as far as we will be reporting out our work thus far at the July 10th meeting. If anybody has any recommendations on how they would like that to be. In the past, we've just had Dr. Kearns share what our current recommendations are. And I believe that is the meeting that we would be sharing the status of that at this point in time. Although there will be still definitely more time to add to that and continue to increase it. This agenda item can also still be on the June meeting. So we will have an opportunity to talk about the July report out in June as well. So is there anybody from the committee that has any thoughts as far as the report out for the July 10th surge meeting? And again, we'll have this conversation again in June, but if there's anything that you're considering at this point in time.
The only thing I would ask is, Christine, I don't know when you'll meet with the Nevada Sheriffs and Chiefs again, but will we have any, do you think, a recommendation or anything from them before our July 10th surge meeting?
I'm not sure when I'll meet with them either, but I do hope that via email that I'll get some responses and recommendations.
Great, thank you.
Fabulous. Well, just a friendly reminder, Chair Ford shared in April at our last all surge meeting that he was asked to present to the interim standing committee on health and human services. And that meeting is on May 13th. So if anybody was interested in being there to support Attorney General Ford and his report out, or you just wanted to listen in, that's May 13th. I believe that is available, or it looks like Crystal just put it in the chat, but also I believe you can find that via the Nellis website to be able to hop on if you're not able to be there in person. Also
It'll
Attorney
start
General
at 9 a.m. Just
start at 9 a.m. Good call. Plan ahead. Wake up earlier, plan to travel. Attorney General Ford is also going to be presenting to the Washoe Behavioral Health Policy Board in the afternoon. Is that the same day? Same day. He's busy presenting. Thank goodness he's a good talker. And then also for those of you guys down in the Vegas area, if you were planning on attending the July All Surge meeting in person, you might want to note that the location has changed or will be changing. It will be changed by that date. They're moving into a new office building at 1 Harrah's Court in Las Vegas. Zip code 89119, just in case you need to put that in your GPS for specifics. But eventually that's gonna become the one state of Nevada way. But for now, that's 1 Harrah's Court. And the agenda, when it gets posted, we'll have that information on there, but just so you guys can have in your brain, because sometimes we look at those agendas and we just scroll right past that technical part up front. And then next thing you know, you show up at a building where nobody's at and you would be bummed. So please note, if you're in Vegas and going there in person, you're going somewhere else next time.
I would just add that the move for the Attorney General's office is scheduled for June. If it gets delayed again, we will let you know. And that's why we wanted just to remind everybody that July 10th meeting will more than likely be in a different spot.
And of course, Zoom will always be an option. So if you are just not sure, plan to Zoom. But if you're like me and your internet cuts in and out and you just choose to be in office location because you want to make sure they get to hear you and your awesomeness, go somewhere else. I think that wraps up this agenda item unless there's any other thoughts or considerations in regards to the report out for our July meeting. I think in June, we're gonna have more direction for you, Terry.
Yeah, no, that sounds good. I think we're in a good path. We've got some recommendations, some coming, and some things we can continue to look at.
So with that, I think we can move to agenda item number 8. Final public comment, and I will let Terry do her thing on that.
Right, thank you. Again, public comment. We ask that you limit it to 3 minutes. You can dial in at 669-444-9171. Enter meeting ID 868-3331-1069 and press *9. I will open it up if anyone has public comment at this point.
I currently don't see any raised hands or anyone coming off of mute.
I don't either. So I would say that at this point, we can adjourn the meeting and we'll give you about 25 minutes of your time back. And if anybody's interested, I believe the prevention subcommittee is currently ongoing too as well. So thank you all, and we'll see you at the next response subcommittee meeting. The meeting is now adjourned. Thank you.